Good morning and welcome to this edition of YouTube channel. This topic is about barbiturates. Whenever you go into the faculty of anesthesia, this is the first drug you will see or you will use most probably. And this is necessary or a must-know area of knowledge in anesthesia. So, if you are not subscribed, you put a click into the subscription of our channel to see more videos on anesthesia with different type of teaching material. And welcome from and greetings from our medical institute, Balaji Vidyapeeth University. So we will go to the synthesis of barbituric acid. This is actually got from urea and malonic acid to give a barbituric acid. Urea plus malonic acid is equal to barbituric acid. Now, barbituric acid is simply not hypnotic. You need to have some sort of substitution. Some groups here at 2 and 5 to make it as hypnotic. Now you see this is barbituric acid, and if you have an oxygen here, and this is here you can see here barbituric acid, methoxetal. This is thiopental and this is thiomylan. See, if you see, this is oxybarbiturates. This is thiobarbiturates. Thio means sulfur. So thiamylol, thiopental or thiobarbiturates, and methoxetal is an oxybarbiturate. Now we are not using much of oxybarbiturate because thiobarbiturates are more lipid soluble, they are more rapid onset and a short duration of action. Oxybarbiturates are known for their excitatory phenomena. Barbiturates especially, this is acidic in nature in the presence of hydrogens because of hydrogen ions. But the sodium salt of barbituric acid is water soluble and gives a highly alkaline solution. This is also there is a keto-enol tautomerism. Keto-enol tautomerism in barbituric acid. So it is basically acidic. If you combine with the sodium salt, it becomes alkaline and it establishes keto-enol tautomerism. This is barbituric acid was actually invented by in 1864, but we gave thiopental in 1934, and Ralph Waters, who make this anesthesia record initially, was the pioneer in using this thiopental. Rapid action and rapid removal, because if you give thiopentone, the patient becomes under in 14 seconds, probably in one arm circulation time, one arm brain circulation time around 20 seconds. But they become conscious in 5 to 10 minutes. They thought the thiopentone was removed from the body. High doses and deaths. This lead on to so many deaths, and this was the use of thiopentone was then told as the ideal methods of euthanasia. War casualties in Pearl Harbor. So patient came with war injuries. They gave thiopentone to do some suturing to decrease bleeding and all. If you give thiopentone in high doses, because they thought it came in and went out, they did not have an idea about redistribution. So this happened in 7th December 1941. So many deaths in the Pearl Harbor war casualties. This is termed as Pearl Harbor tragedy. Brody and Price later told it is not elimination, it is distribution which causes the action to terminate. Causes of termination of action is redistribution and not elimination. Thiopentone or thiomylan, thiopentone or thiopental, UK or USA. Long acting, short acting, ultra short acting is not valid now and is slowly obsolete. Commercially available sodium thiopentone is a pale yellow. Yellow is because of the sulfur. Hygroscopic, it absorbs water. Amorphous means, morphia means there is some shape. Amorphous means there is no shape. It smells of garlic or hydrogen sulfide. The powder contains 6 parts of anhydrous sodium carbonate as buffer. 6 parts means 6 milligram per gram of thiopentone to prevent precipitation of insoluble acid formed by the atmospheric carbon dioxide. So the atmospheric carbon dioxide should not come in and precipitate this. So they have made it as anhydrous sodium carbonate 6 parts along with this atmosphere of nitrogen inside the vial. The vial contains nitrogen instead of atmosphere. A decrease in the alkalinity of solution can result in the precipitation of free acids. So it becomes some thick precipitates will come if you add linger lactate. Yellow color is due to the presence of sulfur molecule. The powder is soluble in water, saline, and alcohol. See here, 2.5% solution. pH is 10.5, which is highly alkaline. The pKa is 7.6. If you have deep breath, alkali, less drug is needed. So again, I am telling 2.5% means 25 milligram per ml, and this pH is 10.5, which is highly alkaline. These alkaline solutions are incompatible for mixture with drugs in acidic solutions. Don't mix pethidine and barbiturates. Don't mix NORAD and barbiturates. All these things are slightly incompatible. They can block the cannula and there's no pain on injections. That is the advantage of thiopentone. Not much of pain if you properly administer, unlike propofol. The bacteriostatic property, yes, we can do multiple injections and give, but this is not due to some bacteriostatic. This is because of the highly alkaline pH. The powder form is stable at room temperature. The reconstitutions can be used for 6 days, and there are opinions differ because some say it's 1 day, but if you keep it in fridge, it can be used of 2 weeks and throw out any cloudy precipitated solution. The usual IV induction dose is 3 to 5 milligram per kg in adults. 60 kg means 180 milligrams. 70 kg means 210 milligrams, 3 to 5 milligram per kg. 5 to 6 milligram per kg in children, and it all depends upon the pre-medication and age. Just don't inject like that. Retal is 6 to 10 milligrams and methotrexate is 1.5 milligrams. That is what is the calculated dose versus titrated dose. For example, now you are having a sick perforation. The patient is in sepsis. You give good dose of morphine. You give good dose of midazolam. Wait for 3 to 5 minutes. This is what is essential. You have to wait for the morphine and diazepam to stabilize and act, and then start your titrated dose of thiopentone. These patients, 65 kg patient who is hemodynamically slightly unstable peritonitis, may not need more than 50 milligram of thiopentone, hardly 0.75 to 1 milligram per kg of thiopentone. This should strike into the minds of all learners in anesthesiology. It is not that pushing 3 milligram per kg of thiopentone, that is 4 milligram per kg of thiopentone, some 60 kg, 240 milligrams IV like that. All we use are potentially life-threatening drugs. If you have acutely alcoholic patient, inebriated, we may need less dose. In chronic alcoholism, we may need more dose. Loss of eyelash reflex, a deep sigh and goes into apnea. A tidal volume is depressed rather than the rate is depressed. These are all the signs of the patients getting under. Now you give, yes, for example, now you have given, you think that 75 milligram is enough for this patient. Give 75 milligram and wait for 15 seconds because it has to reach the brain, and then there are loss of eyelash reflex. By this time, you would have given another 50 milligram, which is not needed at all. That is how we should titrate, as otherwise on induction the BP crashes and we may need to start noradrenaline. What is the mechanism of action? GABA A receptor. This is what is the main mechanism of action. Chloride channel, hyperpolarization of cells. So GABA is an inhibitory thing, stimulate this GABA receptor, chloride channels are stimulated and hyperpolarization. There is also a glutamate antagonism and sodium channel blockade in the mechanisms described for thiopentone. Pharmacokinetics. Volume of distribution is 2 liters per kg, may rise to 4 liters and 7.8 liters in obese patients. Clearance is 3.4. Protein binding is highly protein binding. That is why in patients with hypoproteinemia, we should be careful. This is what I was telling. As soon as we inject, in 10 seconds you see the blood. And in the brain it is around half a minute. In 30 seconds it is high, half a minute. But it comes down in the brain, so the patient becomes conscious at this time, or around 10 minutes. But the patient body has got still thiopentone. This is what is redistribution. Pharmacodynamics, dose-dependent depression of the cerebral cortex, ARS, medullary center in sedation, hypnosis, anesthesia, and respiratory depression. ARAS, medullary centers, cerebral cortex. So cerebral cortex, ARAS, sedation, hypnosis. Medullary centers, respiratory depression, and cardiovascular depression. CMRO2 is decreased, MAP is decreased, but perfusion pressure may be maintained. Anticonvulsant effect, isoelectric EEG. This is not with methotrexate because it is potentially seizurogenic, but thiopentone is an anti-epileptic agent. It is somewhat anti-analgesic also. Rate and dose matters. That is what I told. Give slow. 15 seconds means less dose is needed. It has been suggested that barbiturates also possess neuroprotective properties secondary to their ability to decrease oxygen demands. Alternative explanations is the reverse Steele or Robin Hood effect, free radical scavenging, stabilization of liposomal membranes. All these things have been told as mechanisms of actions of the so-called neuroprotective activity of thiopentone. Barbiturates have a place in the therapy following resuscitation, but incomplete brain ischemia may be used like this, but still it's a matter of debate. What are the actions in the CVS? Peripheral vasodilatation, myocardial depressant, and this vasodilatation is predominantly venous and the blood pressure falls. More with MECO because the tachycardic response is less. So on beta blocker, beware. So because there's a mild tachycardic response with thiopentone. If this thiopentone's tachycardic response is preserved, then the cardiac output may not come down so drastically in sick patients. So in sick patients or in patients with beta blocker, where this tachycardic wedge is depressed, then we may need to be aware about the dose of thiopentone. Action on respiratory system, depression of ventilation, decreased sensitivity to respiratory center, and apnea may be present in 30 to 40%. Laryngeal and bronchial reflexes are not much depressed in low doses. This is the difference between propofol and this is the difference which makes it slightly questionable in patients with active wheezing. That is why laryngospasm and bronchospasm, beware in patients who is going to take thiopentone. Apnea, there is a double apnea, 1.5 minutes, and sometimes little later also, followed by this is what is lengthier apneic period. So we may need to see again and assess breathing. Exact reasons are not very clearly explained and they don't occur in all the patients. Decreased hepatic blood flow. Now we have told what happens in CNS: anesthesia, sedation, hypnosis, neuroprotection, and analgesia. Then we come to CVS, myocardial depression, venodilatation, cardiac output decreases, but here we will think of the tachycardic response of thiopentone. In respiration, yes, tidal volume falls, the respiratory rate also falls, the carbon dioxide response is decreased, all these things happen, and it goes into apnea. There are two episodes of apnea. So these are all the thiopentone. So this is about main thing, CNS, CVS and RS. The hepatic blood flow is also decreased and moderate decrease in renal blood flow. Placental cancer is present but acceptable. Yes, that is how it is safe in patients in pregnancy. Induction of anesthesia, maintenance of anesthesia in patients with increased ICP, anticonvulsants, neuroprotection, narcoanalysis. All these are clinical uses of thiopentone. This is what is called truth serum. That is how if you inject, they will tell the truth. That is why they called it as truth serum. Barbiturate coma, severe intracranial hypertension, a 10-year experience, excellent results they have given. Awakening may be delayed in older patients and awakening is better in younger patients. This is very important. What are the contraindications? Absolutely, there should not be any doubt. Acute intermittent porphyria. Thiopentone induces this aminolavulinic acid synthase, ALA synthase. Thiopentone gives in induction. So the production of heme is accelerated and precipitated. Patients going to collapse or paralysis. So acute intermittent porphyria, complete contraindication of thiopentone. Yes, we can have in barbiturate allergy, in asthmatics, and history of paradoxical excitations. Think before thio in shock states, stenotic, right to left answer. If in mitral stenosis, it should be completely titratable. Acetamidate is better, some sort of ketamine is better. If you don't have these things, yes, you can give thiopentone in absolutely titrated doses after an adequate dose of morphine. Myxedema, muscle dystrophy, thermally injured may need more on disulfiram. Be cautious. Stop injection, leave the needle, dilute with saline, inject local and papaverine intraarterially. What are these treatments for? This is treatment for intraarterial accidental injection. That is why if you have a patient to start induction, don't put here IV if you are planning thio. There is a danger of aberrant ulnar arteries. So put here if you have a good vein if you are planning thiopentone. Why not venous? So venous கொடுத்தாலும், you can have thrombophlebitis. You can have your alkaline pH irritating the vessel. But the thing is, venous vessels are not that much tuck construction to any irritation. They are more, what you can say, less vasospastic. And another thing is, as soon as the veins go, they become bigger. But in case of artery, they become smaller. That is the most important thing about intra-arterial dangers. Other side effects: euphoria, vertigo, restlessness, hemolytic anemia, tolerance and physical dependence, localized muscle spasm and pronation. Narcotics will lessen. Yes, sometimes we can have some muscle spasm and the patient may pronate. This can happen with thiopentone. Yes, but if you give good dose of fentanyl, midas and all, these things are less. Yes, this can happen in patients whom narcotics are little less indicated, like patients coming with antenatal cases. Now we have a summary. Our barbiturates can be divided into oxybarbiturates and thiobarbiturates. Thiobarbiturates are more common, rapid onset, less duration. Yes, they are not seizurogenic. Oxybarbiturates are seizurogenic and excitatory phenomenon like methotrexate. Acidic but sodium salts are preparation vials in nitrogen atmosphere in patients in the vial of sodium carbonate to prevent precipitation by atmospheric carbon dioxide. Euthanasia and Pearl Harbor, because they thought when you give thiopentone, patient becomes under. When the patient becomes conscious again in 10 minutes, thiopentone is gone. It is not gone from the body. It is redistributed into non-brain tissues. So they thought and used thiopentone in high doses and killed many. That is what is called the 7th December 1941 Pearl Harbor tragedy of war victims. The mechanism of action I already told. GABA stimulation, chloride activation, sodium channels, and glutamate are also involved in this in a minimal way. I have already told dosage 3 to 5 milligram per kg. It may go up or may down. Well premedicated, titrated dose is necessary. Sometimes you give calculated doses if you want to make it chadak in patients with rapid sequence induction in pregnancy. Effects I have already told: CNS, CVS, RS, hepatic, renal, etc. Indications: not only anesthesia, sedation, ICU, fits, status epilepticus, neuroprotection, barbiturate coma, so many things. Contraindications: acute intermittent porphyria, shock states, history of barbiturate allergy, and patients in shock, yes, definitely. Side effects already we have told. And thank you all, and subscribe to the YouTube channel Painfree Partha and visit painfreepartha.com website and for slides.